Looks like they changed the format on Google Meets, but that's okay. So I was going to do a very personal case study, but I can't download the file. And the personal case study is my granddaughter's MRI from when, within a year of her birth, to show you what they were able to ascertain from that, and then to demonstrate a few things. But that was less about the therapeutics and more about the diagnostic value of imaging studies. So hopefully the next time I get together with you, I will. It's funny. I think it has more to do with the university software permissions, because when I was able to, my son sent me this gigantic file, like 160 megabyte file, with all this material, and I could open it on my, I have a PC all-in-one that I use at home among several computers, but I never tried it on the university laptop, and who knows? I mean, because I'm supposed to meet with them at some juncture today or tomorrow. I'll see if I can get that software on it anyway. So it took away one of the things I was working on, but I've got others. So I really just wanted to go over some case studies, both good and bad, because really that's from a standpoint of what we have to share with you, at least what I have to share with you. At this point, I think it's more interesting, more fun to look at things that are clinically relevant than sit there and go, the GI tract, we're going to lose a certain kind of a cell, or microvilli are going to disappear, and you're going to have malabsorption syndromes, or whatever is necessarily associated. So a couple of things I found. We'll start with this. This is a really good, and I already have it cooked up. So I will make a note to send you the link about this, okay? And this, I don't know how I found it, but I don't know what WSTO. Oh, Washington University of St. Louis. Okay. Which just so happens an old high school classmate of mine is a retired professor in a different discipline in psychology. So for some reason, they had a listing of these cases, and I really think they're helpful for you to look at. And I think that's going to be an assignment that and I'll talk to Dr. Buxton about it, maybe tomorrow, certainly on Monday, in preparation of him being with you next week, about what we're going to go over. So I'll have a chat with him about that. He's in a good mood anyway. Liverpool won yesterday. We're soccer devotees. My team's doing lousy. His team's doing great. What are you going to do? So if you take a look at this list, bang, look at that. So wherever they've got a variety of case studies that, and not all of them are necessarily available, and there's probably some HIPAA stuff that goes inside that. I'm sure they educated you, or they will, about HIPAA and all those kinds of things, right? Yeah, I mean, because it's big time. To me, if they publicize any of these, and I'll get back to this, if they publish them and they're readily available, if their ones are not there, it's because someone has not approved of them sharing that, for educational purposes, things are relatively liberal. So I have that same thing over here, and I'll go back to that in Jeff. So, I mean, the first one I found was this: occupational radiation disease, skin injury, and leukemia after accidental radiation exposure. Well, the first thing I thought of is, I mean, who would be subject to having an accidental radiation exposure? People working in the industry. So, I mean, if you're working in a hospital or an outpatient facility, those are all the things that you have to be so concerned about. And sometimes you have an occasion to take those things for granted. So when I had an office, I had 2 X-ray units in my office. This is a long time ago. Okay. And it became relevant as they began to supervise these things from Pennsylvania. So it was under the auspices of DER. So I had a guy every year, came from DER, plenty of notification, and examined my X-ray units. And he got into the back where the X-ray unit was, and make sure we had adequate lead shielding, which I put in the wall to avoid scatter, and all of those things, just to make sure, and he tested the machine to make sure it was doing exactly what it was supposed to be doing, even though the machine cost a bunch of money, all that. But that's the idea. So you'll have to work under the assumption, I think, in your endeavors that everything's up to speed. So are you responsible for making sure with the equipment that you're going to be using and working on patients, that they school you and making sure that, all these things? I'm guessing. You have to tell me. Is that something that you've been instructed in so far from a clinical perspective? Yes, no? I just wonder what steps you would have to take on the inside. So long story short, so this is something, I guess this must have been published out of China from Public Health. As you can see, whatever the provincial did, follow-up observation of a radiation accident in which a worker developed an acute radiation disease. And as you're going to see, one of the significant things that we see afterwards, and it's something that they really identified for a lot of things post Hiroshima and Nagasaki, and certainly post Chernobyl, was the leukemia being really significant because it destroys the bone marrow and alters the bone marrow. And then aberrant cells can take over. So radiation exposure at various stages, 28-year-old male. They looked at chromosomes, white blood cells, sperm count. So if you were looking at female, you would probably be looking at the egg-related, not so much the count because it's different because because there's a vast, vast number of sperms in an ejaculate. We're talking about 300 to 500 million sperm per ejaculation, relatively easy to produce rather than obtaining, which you have to do surgically to turn an egg to look at for chromosomal purposes. So after the patient was irradiated, white blood cell decreased, sperm count dropped to 0. Libido completely disappeared. So obviously had this very significant effect. Biologically, sperm count, at least in the male, and the female is a bit more complex physiologically vis-a-vis things like libido. But those alterations undoubtedly, played a role with testosterone production, which plays a role in both the maleness aspect, and testosterone-like substances probably account for libido in the female as well. So, I mean, I'm not surprised by any of that. So you can look at these. They give you an idea. Leukemia diagnostic experiments, bone marrow examination, abnormal proliferation of lymphocytes, which are one of the white blood cell lines, extracellular iron staining, another sign that pointed to things. Patient died of acute lymphoblastic leukemia 34 years after the exposure. So it took a while, but eventually it became acute in nature. Okay. So they're just telling you what happens with iron. So you can look at it in therapeutic doses for good, or you can look at it in whatever would cause an error in dosing. Hopefully it would never happen, but is it a machine failure? Is it a mechanical failure? Did a button get stuck? And I often use the analogy. It's like everybody in the room knows somebody who is diabetic and has to test their sugars, right? They have a glucometer, they finger stick it. And this is what I basically tell them about. It's like, well, if you could test your sugar every day and say, boy, for last week, my sugar's been 85. I'm doing great every time I've tested it. Now, that would be highly coincidental because sugars vary constantly, even a subtle amount. Even if it was around 85, you'd say plus or minus 5, plus or minus 4, depending on what you've eaten recently. Or there could be the glucometer could be messed up and always reads 85, which would certainly give you a false sense of security. So the whole idea of calibration is where that comes in, and inevitably there's going to be calibrating circumstances for all of those things. So that's where it kind of comes from, the mechanism of action, and then they look at those effects. I think you probably heard about these stochastic versus deterministic effects. Okay, stochastic effects include, and those are important terms for you to know, sure. Cancers in exposed individuals due to somatic cell mutations and genetic effects in germ cell mutations. So you can read that as eggs and sperm. Somatic cells are all the rest of the cells. Everything. So it induces malignant tumors, which have been confirmed by a large number of animal experiments. These days, hopefully we're doing less of those. And what they're doing in China, I don't know. And human epidemiological studies. The genetic effect induced by ionizing radiation is still lacking epidemiological evidence, and such effect has only been found in animal experiment. Okay. So these are the things that they see a lot of: leukopenia, low white blood cells, bone marrow damage, cataracts, radiation damaging and effectively producing cloudiness in both the lens and in the cornea. And that has to do with alterations in the protein structure, which makes those structures transparent that are there. Erythema, depilation, redness and loss of hair, skin damages in general will be part of that, or what they call deterministic effects. So we're looking at mutations on a cellular basis, whether they're regular cells or germ cells, egg and sperm cells, reproductive cells, or whether they're secondary effects, if you want to think of them that way, in actual structures. So here was an X-ray inspection worker. Someone came to take a look at an X-ray unit, accidentally exposed to uneven systemic radiation, disease, acute bone marrow, et cetera, et cetera. So that's really interesting. This person was born in 50, X-ray inspections, part of 74, 24 years old. December, in the middle of the night, December 78, slept at the back of an X-ray flaw detector without knowing that his colleague, and this was an industrial unit. So could that happen to somebody who left something on and you were in a room for a long period of time? I thought so. 30 minutes, long time. How long do you press a button for an X-ray? I know every time I've had accessory, they go, hold your breath, and I hear, right? So it could happen if somebody left a device on without your knowledge. You're going in there, setting up, organizing, maybe decide to have a mini coffee break in there in between patients. I don't know. That kind of stuff. And they give you all the numbers. Nausea and vomiting 4 hours after the exposure. So those are the kinds of things that, and I think this is just, to me, and the way I want to present it to you. And what if I'm really feeling ambitious, maybe I'll concoct a case history that's something like this and have you respond to it or comment on it briefly. This is not a communications or writing course. You don't have to ever write the great American novel, because I'd have to read it. And I'm lazy. And so that indicates I like a paragraph or two. You'll be happy to hear that. And we grade very generously. So initial reactions, it sounds like me most mornings. Not the nausea and vomiting, fatigue, dizziness, insomnia, dreaminess, and the decreased appetite I haven't been blessed with. Mine's always increased. Opportunity to laugh. Thanks a lot. It doesn't work that well. Terrible. So 15 days after exposure. So look wherever he was situated, laying down, sitting, that was the area that was most greatly exposed. Right side of the thoracic area, the chest area. Okay, pretty large flaps, 7 by 8 centimeters, 3 by 4 inches, blisters, and a variety of areas, scarring that occurred there. Now they're talking about the impact on the sexual or libido prospect. And again, it was somewhat limited there. And then look what happened. So now we're starting to see what happens. And it kind of goes along a little bit with those curves that if you recall, that we talked about, that had that like humped curve where things, and it's a bad example, but what it underscores is things don't show right away. Okay. So I think it's the type of thing that you have to be wary of. Maybe tell people about it. I don't know, whatever they instruct you to do. Whatever protocols that you have when you're actually dealing with individuals, because that's what you have to find. I have occasion to say that in every class, and I will continue to say it from someone who was licensed at one point in one field, 4 state, and held 3 board certifications in 3 different subspecialties. Licenses are very hard to get and very easy to lose. So there's an old saying that doctors tell to one another. I will not express it to you. It's DFU. The first one is don't. And the other one you can guess. Just saying. You'll find that doctors speak in colloquial English like I do, or are fluent in another language, profanity. We do that. WTF not? Okay. So 19 months later, condition improved, ulcers on his back did not heal, radiation burns, etc. A variety of treatments. 30 years showed no local skin ulceration or cancer after the skin grafting procedure that was done. And here, 34 years after the exposure, now you get the real problems that are there. And finally, after a rather long, significant period of time, acute lymphocytic leukemia. And they give you the white blood cell counts, etc. And I mean, and I always, figures are interesting if you're of any, if you want to look at those are, you can see chromosomal irregularities if you know what you're looking for and that type of a thing. Just saying. So table 1, semen and chromosome aberration times after irradiation. So, I mean, sperm counts that were dramatically low, chromosomal aberrations that were high, and then eventually after years went down. Okay. But those sperm counts, what I'm telling you, 10,000 per milliliter, that is in terms of sperm counts extraordinarily low. Okay. When there, if you, someone like that, that would be one of the studies you would do for infertility. And because my first wife and I were an infertile couple, those are tests that I had to have done. So they look for your count. For the male, they look for count and motility. In the female, they look for other things. In general, broad statistic, when it comes to infertility, which is a significant problem, and more so these days because of environmental exposure, the old school was about 60% of the time it involved the female, 20% of the time the male, and 20% of the time not clear. Just in case you're wondering. And it's interesting that case study I was going to show you about my granddaughter was, so both of my grandchildren on that side were conceived via in vitro fertilization. And my stepdaughter-in-law and stepson are undergoing that right now. So it's becoming more frequent than one thinks. Does that mean because of the vast radiation? I don't know. Do I think it's environmental factors? Yeah, I do think so. So just saying. So let me get rid of a couple of these and go back to what we're going. They diagnose leukemia, and then so combined with the initial clinical manifestation, lab doses, and other data, etc. Look at what a skin injury grade 4, very severe, but only mild acute radiation disease. But then a big change because you went from myeloid to lymphoblastic. That's 2 different systems. Not that I expect you to know about that, but those are 2 different kinds of bone marrow involvement. And here's the discussion that goes along with it, etc. And you can look at, and I would suggest you look through this, what happens, and they give you the idea of what the dosage is in grays and things like that. One vomiting in the early stage, no typical symptoms, etc. But I mean, so you can read through this, and there's quite a bit. They've gone to quite an elaborate thing that's involved with it. And then all of these different statements that whenever you publish information. In this case, chromosomal aberration, peripheral blood lymphocytes was still detected within 20 years follow-up. And so eventually that led to, it's almost as though those chromosomal aberrations and lymphocytes took an extraordinarily long period of time. Okay. And so you can look at the other things that are there. Relevant studies, ionizing radiation, cluster damage of DNA generates secondary DNA damage, the involvement of the free radicals, all things we discussed. So that was the very first case that I found. And I knocked that out. Here's one involving tumors associated, published relatively recently. That's not even 2 years ago. Okay. I'm not sure where it came from. Breast cancer patient. So breast cancer is the cancer with the highest incidence of mortality worldwide. It's an enormous statement. I don't know that we do enough about that. Maybe that's a good area for me to think about for doing those types of things. The numbers are horrific. I do not know if you had these numbers, and you probably heard about them in the past. We're looking at maybe 1 in every 7 women carrying that diagnosis. Not always. I mean, for men, maybe about 1 in 8, 1 in 9 have prostate cancer. I had prostate disease, so they did not observe any cancerous changes. And simply, I'm very thankful for that. I already had bladder cancer, and the systems are obviously intertwined. Remarkable types of things. My mom got that diagnosis many years ago, and fortunately, it turned out what was called cancer in situ, meaning it was very, very isolated, and they were able to, once it was removed, basically nothing else happened thereafter. And that probably happened when she was in her 70s. Okay. So highest incidence of death, mortality worldwide. Ouch. Multidisciplinary treatment, surgery, systemic therapy, radiotherapy. Age, standardized incidence rates of 44 per 100,000 women. Pretty scary. Et cetera, et cetera. 7 Colombian patients treated for breast cancer at our institution developed radiotherapy-induced tumors between 2008 and 2018. Median age, roughly 55. Locally advanced tumors at the time breast cancer was diagnosed. All of them received adjunctive or additional therapies with chemotherapy as well as radiation therapy. So it wasn't just radiation therapy alone. They tell you the different types. Sarcomas are the most common radiotherapy-induced tumors after breast cancer treatment. They're rare, they're aggressive, okay? That's between like roughly 1 in 200 to 1 in 20 of all sarcomas. Sarcomas are bad. Basal cell carcinoma, which is comparatively more common, that's more of a radiation burn. That's a relatively common, fairly easy. If you're going to have skin cancer, that's the one you would want to have. Not that I'm recommending it. So as they become in, the numbers are staggering. This is an article from 2020. A total of 2 million plus new cases reported in 2018. 11.6 of all cancer cases, the number of deaths, extraordinary. So they go into all of this, the different kinds of radiotherapy that can be used, the different criteria that are there. And so here's the case that they were talking about. They identified the different kinds of tumors. They looked at that breast cancer gene that's become so terribly relevant today, etc. Here, just look at the studies that are there. Thoracic computerized tomography in a variety of sections, intraclavicular mass. So, I mean, I think we're looking up in this neck of the woods up here, and on the thoracic wall and axillary extension, all coinciding with radial fields. Preoperative versus postoperative views, etc. So as we begin to look through the rest of this, the cancer entity most frequently diagnosed, overall survival rate of patients with early breast cancer increased over the years. Good news. Chemo, hormonal, targeted therapies, probably radiation or interventional radiology of some type. And so you can see that, I mean, I think we're seeing a lot of these. What genomically, this is what we see a lot of with what radiation, with ionizing radiation and a variety of cancer-causing agents, chemical agents do. They alter what are called proto-oncogenes. Oncogenes make tubers. proto-oncogenes are the precursor stage, which don't make tumors. When they're changed, and the analogy is like a car accelerator, they get stuck, and it's constantly accelerating. Okay, so that's one of the underlying problems that are there. Again, the sarcomas are comparatively rare, and they do a variety of things. Okay, so here they're looking at the Curie Institute in France. It's a very famous, I'm sure you studied about Madame Curie. There's either a Netflix or a Prime movie about her. That's actually pretty good. You get a chance to watch that. So it involves she and her husband and the research they did in radium. And obviously both unfortunately succumbing to a radiation-related disease. And so all of that's part of it. And so you can see this, they reviewed 16,000 patients, 27 sarcomas were found. And then look at the time interval between the irradiation and the tumor, 3 to 23 years. So the fact that you're treating somebody, it doesn't preclude that there are potential damages that are there. And they go into this, and I don't see a whole lot. Tumors, but the conclusion to me is relevant. So tumors associated with radiotherapy are a low incidence entity, but high aggressiveness. So even though it doesn't happen that frequently, when it does happen, it's particularly problematic. So and you're probably going to see individuals who this may have happened to. Okay, so it's something I think maybe to be on the lookout for. Maybe in somebody who's had previous treatment, to begin to ask them if you can about anything that they're experiencing. And then they go into all the different things and they reference it. That's lovely. So we can just to show you. And then these are short. These are short and to the point with these kinds of things. So these are all Washington University in St. Louis, Missouri. And I start looking through them to see what they are. Several of these involved, interestingly, sickle cell disease. Okay. I have a fair amount of experience with sickle cell disease when I was a medical student. It's a long time ago. So it's going to be 46 years this summer. Okay. That I worked in a clinic that dealt with sickle cell patients in Virginia, which there was a fair amount of enrichment. And and I learned a lot about the disease. We were treating them for skin ulcerations. Okay. Because what I did not understand is all the clots and all the organs. So when the blood would clot, sickled blood, when there's a lot of activity or low availability of oxygen or a lot of physical exercise or over time, what happens is those cells clump together very easily, form blood clots, and you don't get blood flow to structures, and structures begin to die. So, and sometimes they would go to the skin. We would treat the ulcerations for that. So here, 18-year-old male, sickle cell anemia, left leg pain. Let me show you a bunch of images. This is a bone infarction. So what's an infarction? By definition, is death of tissue from lack of blood supply, period. Myocardial infarction, heart attack, death of heart muscle from lack of blood supply. Cerebrovascular infarction, death of brain tissue, stroke. So infection and infarction are not interchangeable terms. Okay, so hemoglobin disease, 1 week history of pain, left tibia, left leg. Blood count high, 28,000 lymphocytes. Sedimentation rate, which is a generic test for inflammation. So they want to differentiate between osteomyelitis, a bone infection, versus a bone infarction. And so they used indium 111 that labeled the white blood cells. So if you have a whole bunch of white blood cells in a particular area, it's going to tell you stuff that was there. And they looked at the images. Imaging of the narrow distribution left leg was performed by injecting into technetium 99, et cetera, et cetera. So what they looked at, there was not a significant difference in the distribution of marrow activity of the Indian 111, looking for white cells, and technetium 99. Specifically, both sets of images, there are focal areas of absent activity. Read that as the blood didn't get there, circulation. That's the idea. So what's an infarction? Again, lack of blood supply going to a particular area. If there was a blood supply with an abundant amount of white blood cells, then you begin to start thinking more about infection process. Okay. So normal marrow activity is seen with radiopharmaceuticals. Findings are not consistent with osteomyelitis and more likely to represent an infarct. The whole idea, I mean, if the white blood cells are not attacking that area and if it's not being damaged, okay, and generally we see with an infection is at least early on an increase in circulation. Okay. And so they looked at other images and saw that in the head of the left humerus, shoulder, clavicle, collarbone area, odd areas in the lower lumbar spine, previous infarctions that are there. So it's often difficult in sickle cell patients because of when they present with pain, okay, the difference whether it's blood supply or infection. So they use the white blood cell, the leukocyte scintigraphy, combined with the marrow scintigraphy in these images. Okay. So if you're just using Indian 111 white blood cell, not good enough for those particular scans. So it gives you an idea. There's a lot of these have been studied and really interesting. So I'm trying to look at all of these for you to see if there's, things that were interesting. And some of these, this is normal brain perfusion, evaluate for brain death. 76-year-old man, an abdominal aneurysm, non-reactive pupils. And so effectively, post-operatively, this person became comatose. So they take a look at the images. A prolonged bolus injection may lead to no diagnostic perfusion, but similar appearance is seen in patients with congestive heart failure. Okay. Local, and all these different things that are part of it. And they're just indicating that this study is useful. So a diagnosis of no effective cerebral perfusion, no blood supply to the brain, is made when there is a good bolus, an amount that goes in there into the carotid arteries, but it doesn't get through the area that supplies the brain, which is known as the circle of Willis. So that's what they're kind of talking about. Okay. And I can't discern terribly well, but it looks like it's not getting all the way up where it's supposed to. That would just be me. And so if somebody with an aneurysm that they tried to repair, it means that the blood flow just didn't get where it was supposed to go or for a sufficient amount of time that was there. So you begin to think. So you had the normal brain perfusion study. This, when I tried to look for the brain death, I couldn't find it. Let's see. Very significant disorder. We see it in growing bone. So you can take a look at a scan like this, at a bone scan like this. And I don't know how well you can see it over there, but if you look at the areas that light up, here, that means growing bone. In boys, bone can grow, we can have growing bone up to age 20 or 21. In girls, it probably by about age 15 or 16. And it's all about something called the growth plates. And the growth plates close, which generally mean most women have reached their adult height, size, as it were, from a standpoint of elongation. So you're not going to get a whole lot taller. Your hands aren't going to get a whole lot longer. Feet tend to change a little bit because of weight bearing over time. So sometimes you get a little bit wider. But those are open growth plates. It could be a boy or a girl. Okay, then you'd have to determine boy or girl. I know it was a boy because of the pelvic appearance is one of the areas where you look at that. But look down here. Wow. So here's right knee pain. Take a look at that. That's here. And here you're looking from behind. So this is anterior, looking from the front. See the toes are forward. Here's posterior, looking from the back. So there's little clues to look at things, to see which side is which. So here, right and right now, looking from the back side of things that are there. 11-year-old boy developed knee pain, progressively worked over a month. No real history of trauma. I mean, it's not saying they twisted a knee badly or tore a ligament or anything along those lines. Patient had intermittent fevers and mild weight loss. That's interesting too, because that generally 11-year-old boys are healthy. Physical examination, a mass on the medial aspect of the right tibia. This is the most common area for there aren't a lot of bone cancers in children. Osteosarcoma is that. Sarcoma means it's made of connective tissue. So bone, by definition, is connective tissue. This is cartilage. The only treatment for that, I will tell you right now, an 11-year-old boy is one, amputation. There have been a lot of famous cases. One of the late Robert F. Kennedy, President John F. Kennedy, had 11 children. He and his wife. One of the sons had that early on. That was after President Kennedy had been assassinated back in 1963. So the palpable mass, and so you send it to an orthopedic surgeon, and the first 63 things you're going to think about is tumor. Okay, so they took plain films. They saw plain films, just regular X-ray, saw a mixed sclerotic lytic lesion. And so what happens in osteosarcoma, you have, because it's growing bone, it's being built up, and you have a tumor, it's being destroyed. So it's a mixture. Okay. So that's typically consistent with osteomyelitis, less likely than osteosarcoma. And they put a marker, something over that to see where it was. Marked increased activity in the proximal third. That's a lot. That's a big area. With a second focus more distally. So that's where you get, it's with an osteosarcoma and with infectious, a less likely possibility. Okay. They did an MRI. Okay. Proximal tibia, metaphysis is the shaft. Epiphysis is the top or the bottom, but not involving the knee joint. There is a skip lesion more distally in the tibial diaphysis in the shaft. Okay. And they have a break, which is called a pathological fracture. Destructive lesion, cortical breakthrough. Okay. So all that bad. So if you go back up and look at this, I mean, they're starting to see this, and this is that skip lesion here and the skip lesion here. Bad news. It's kind of one of those things that I hate to say it, as a doctor, something I guess the way to describe it is you think of the worst and hope for the best. So you always have to in the back of your mind. And it's one of the first things that I learned is what would be lethal, what could kill somebody, because you have to address that. Some things you just don't have a lot of time about that particular thing. And so they look at all those things, the major teaching point. So you're using it, okay. Typically for bone scans, you're looking for typical ways to look for, you're not really to look at the type of tumor, okay. It's not necessarily the best thing for osteomyelitis from osteosarcoma. There's other things that are involved with it. So it really needs additional testing. That's part of it there. Paget's disease is a real oddball, okay? Prostate cancer, okay? Prostate cancer, remember I told you last time, when prostate cancer moves into bone, it causes bones to overdevelop. So you see increased activity, deformity, etc. Dramatic example involving the manubrium, it's the sternum up here, vertebrae, the entire left lower extremity. The third lumbar vertebrae has the appearance, I have to look at that, Mickey Mouse. That doesn't look like Mickey. It doesn't look like Minnie. Pluto, Goofy, Donald Duck. Just, I'm old. If you're not parents, one of my colleagues just had this. It's a rite of passage, taking your kids to Disney. Standing in line for 2 hours to go to It's a Small World. Is this ringing a bell with anybody? Twice with my kids. Thank goodness my kids are all into roller coasters because I couldn't go on Space Mountain. Which reminds me, my wife and I are making reservations to go to Orlando right after graduation. Yes. Come on. See you later. Have fun. So, I mean, now you're taking a look at this, all of these things. So, PSA levels stable. That's about prostate disease. Where Paget's disease is an oddball. It shows areas where bones being broken down and building up. It's not a common problem. There's another Paget's disease my mom had of the nipple. I don't know if it's the same doctor who identified it, or they just had the same name, but it's a common, not terribly dangerous form of breast cancer, if there is such a thing. So let's see, more Paget's disease, bone infarcts, myositis. You see a lot of bone-related stuff. Radiation nephritis. I looked at this before. This is a 4-year-old boy who unfortunately had a brain tumor. Okay. And so stage 4 neuroblastoma. Anything that says stage 4 is bad. When you'll hear about this in patients, you will see stage, basically when diseases cross a boundary, it's bad. We have a lot of natural boundaries in our bodies. Muscle is the big boundary. The big one is the diaphragm. It's a dome-shaped muscle between your abdominal cavity, thoracic cavity above abdominal cavity. When it crosses the diaphragm, cancer that crosses the diaphragm, by definition, becomes stage. And that usually means you have somewhat ominous prognosis. So chemotherapy, bone marrow transplant, et cetera, et cetera. They obviously did a technetium-99 label, but this is the one that is accumulated. I forget what the name of it is, methyl di something that accumulates in the kidney. And so you begin to look at these things. So it looked in bone as well, moderately increased activity signal on the medial border of the right kidney. Okay. So in patient with history of recent radiation treatment, radiation nephritis is the most likely diagnosis. So those are things that that you look like. There's a threshold for it with a certain amount of treatment, 2 years after treatment. Okay. And it can be associated with other non-cancerous related factors. I'll see if I'll do one more. If I could see. See, so many of these are bone related. I don't want to go crazy looking at all those. Osteoblastoma. Here's one. So this is chronic nose drainage after having some ear, nose, and throat surgery, probably some nasal surgery that's there. 57-year-old woman had a nasal polyp removed 2 years ago. Clear rhinorrhea, which means drainage from the nose, whenever she bent over. Now, from the left, now from the right. They did a lumbar puncture and a lumbar subarachnoid injection, standard, where you would put things cerebrospinal fluid. So they obtained the image in 620 hours, normal tracer and basic cisterns. Abnormal dystrophy is so tracer extends, the labeled material, inferiorly and anterior into the nasal pharynx into the nose. So they put plagettes in, and those are basically to stop the drainage from going and to sort of contain it in. If anything, so you'd be able to ascertain what was going on. See, what they're looking at, and I'm guessing is like over here. So it should theoretically be maintained within the brain itself and within, let's say, the upper portion of the spinal cord brainstem area, as opposed to leaking in here. And that's one of the risks that's associated sometimes with procedures. Most famously, and why we don't do them so much anymore and do MRIs, they would do a lot of lumbar punctures to see if somebody, they didn't do a thing called a myelogram, where they'd inject radiographic dye inside the cerebrospinal fluid in the lumbar area to see if there's a slip disc. And sometimes it would leak out and it wouldn't heal. And that happened to my wife's best friend, and it happened to my first wife when they were trying to diagnose headaches, and a lot of complications in regards to it. So that's why we've gone more to MRI type things that are less invasive, even scans where you're injecting the dye, not to the lumbar puncture, but elsewhere. So I'll leave it at that. And like I said, I'm going to start to develop some case studies. I really want to move into that. I think it's more interesting. So thanks a lot. I will send this to you. I'll send you the links where I'm going with this afterwards.